Malignant hyperthermia. We want to describe any signs of malignant hyperthermia so we can recognize it before we have to treat it, of course. Discuss the initial treatment of malignant hyperthermia and discuss important steps when initiating malignant hyperthermia in the operating room.
How do I get the current starts?
Hide email. There we go.
We think. Okay, so today we went through the. We're going to try and do a code next week, like we always do a drill, and Dr. Sheff will help me on that. So, what is the history of malignant hyperthermia? It was recognized in 1961, so by medical standards, that's pretty recent documentation. MH is more common in males than females, and there is a familial tendency. MH is rare, it's life-threatening, it's low frequency, high risk. So that's something that a lot of the state agencies and DMV wants to know. What are you doing with low volume, high risk patients and events? So we do mandatory in-services every year on this. It can occur shortly after induction, or it can appear in the operating room during the procedure, or it can appear post-operatively in the PACU. So you have to interact and do something immediately, otherwise the patient will die. If you don't treat this at all, the patient will end up dying. So what causes MH? There's a defect in the ryanodine receptor, which is RY1, which is found in your skeletal muscles. That's responsible for calcium release. It's triggered commonly by the gases that we use in anesthesia and by succinylcholine or nectine. In MH crisis, there's an excessive amount of calcium that's released into your bloodstream. Therefore, you have a sustained, uncoordinated muscle contraction. So the patient's muscles are contracting, and you have a lot of rigidity going on. So because of this, the patient is demanding an increased amount of oxygen consumption, which causes a hypermetabolic state. And this can lead to hypercarbia, respiratory, and metabolic acidosis. Hyperkalemia, arrhythmias, and rapid temperature increase. So in our malignant hyperthermia, we actually have all the drugs that can help reverse some of these entities, okay? In rare cases, MH can manifest 1 hour postoperatively in the PACU, and some research studies show even 4 to 8 hours postoperatively. Okay, so MH is inherited through autosomal dominant transmission, and the carriers are often unaware of that they even have this. Reported frequencies of MH, this is from the MH Society, is 1 in 5,000 and 1 in 100,000 anesthetics. So we still have cases of MH in this country. Based on reports to MH, there are about 600 cases of MH per year still in this country. MH hotspots, I don't know why they're hotspots, but this was interesting, is Wisconsin, Michigan, and West Virginia. We don't live in those states, so hopefully maybe we won't see so much. 5% still do not survive an MH event. Okay, per data from North America MH Registry, of 291 events, 8, or which is 2.7%, resulted in cardiac arrest, and 1.4, resulted in death. So there's still death. 1.4% of these patients still die. The median age in cases of cardiac arrest was 20 years old, and they were doing age range from 1 to 31 years of age. Factors associated with higher risk of poor outcome were muscular built and disseminated intravascular coagulation, DIC, which caused for the poor outcome. Increased risk of cardiac arrest, death, was related to longer time periods between when anesthesia, induction, and the maximum end-tide carbon dioxide, which means the first thing anesthesia is going to notice is a CO2 elevation. So in January 2006 and May 2008, the MHAU hotline received 503 calls from hospitals. 28 of those calls were determined to be malignant hyperthermia, with 2 deaths leading, so 7% mortality out of those calls. 44 calls from ASCs. ASCs are becoming a little bit more inclusive in that they're bringing in more and more patients. Even with history of MH, they're still doing those cases. When ASCs first opened up, they did not do those type of cases. So they're determined, they had 3 deaths, which is 21% mortality rate. So out of this study, they decided that a sudden and severe episode occurring outside of a hospital setting was more likely to lead to a bad outcome. That's what they got from this study. Okay, so prevention. How do we prevent this from happening? The first thing is really good pre-op assessment. That's why we want to call and talk to almost every single patient that comes for surgery. You want to ask if they have a family history of anything happening during anesthesia. If they have a history of muscle disease like muscular dystrophy, central core myopathy, patients with central core myopathy sometimes have a defect in that ribonidine receptor. So if they have a deficiency in the ribonidine receptor, you have to be careful of MH. So a lot of those patients, I know especially in the ASCs, they treat them like they're going to be a potential malignant hyperthermia case. Any concerns or red flags, you notify the anesthesia right away. And I just finished doing 3 in-services for labor and delivery, and they don't do any pre-op assessment till minutes before patients go back, even for planned C-sections. And we came to the conclusion that maybe they needed to talk to these patients and let anesthesia know except for 2 or 3 minutes ahead of time. So we are making some changes here because of some of these in-services. Some of the questions you should ask. Have you or your family members had a bad reaction or a problem with anesthesia? So that way you can find out if there's anything common that might lead you to suspect malignant hyperthermia. Have any of your family members had fever? They may just say, oh, I had a real high fever during anesthesia, but they didn't know why back in the day. So that should be a red flag. I left this up because everybody got a kick out of it. Have you or any of your family members died unexpectedly in OR? Hopefully you didn't, because you wouldn't be doing a pre-op assessment, right? So what are the diagnostic tests for MH susceptibility? It's the caffeine holothane contractor test. And we went up through this last year. It's a muscle that they take from the thigh, but there's only selected places where you can send that muscle. And it has to be performed at the MH biopsy centers. So it's very, very hard for some patients to want to have that done, and you have to wait a while. There is a blood test, which is the genetic testing for the RYRI gene, which we talked about. If you have a deficiency in that, there is a chance. So that this is a blood test, and they send this off as well. Now, if the patient does, or the family member does have a receptor, they can opt through conclusive test for malignant hyperthermia. So if MH is suspected, you want to inform the anesthesia provider immediately. That's number 1. You'd like to schedule that case, the first case of the day, because you want the circuit with a lot of oxygen prior to the case. And usually the anesthesia techs come in and they turn on the oxygen right away when they come in the morning, so there's oxygen flowing through your circuits and everything, okay? You don't want to use any of the triggering agents that cause malignant hyperthermia. Sometimes they may consider just doing it under local or regional. If the procedure can be done with a block of some sort, with just adjunct Zolocane or something, they may choose to go that route, especially if they're really concerned about what could happen afterwards. And you have to be prepared with dantrolene or your malignant hyperthermia cart. You should always bring it to your room, either in the room or right outside the room, if there's any suspicion of malignant hyperthermia. I know I'm going fast, sorry guys. Okay, sometimes when anesthesia suspects that the patient could potentially have malignant hyperthermia, they will keep the patient in the PACU setting or ICU for observation 4 to 12 hours to monitor these patients because they can be at risk. You don't want to send outpatients home, which we do a lot of here, plus in ASCs, and then if they have an episode at home, a few hours later, if they don't get back and get some dantrolene on board, these patients are going to die. So if there's any suspicion of that, you want to keep them and observe them. So what are your triggering agents? It's all of your volatile anesthetic gases that we use. The isoflurane, the SIBO, the DES, the halophane, all of the things that are up there, okay? And you also your muscle relaxant, which is a nicotine or succinylcholine. So what are your early symptoms? You know, back in the day, the blood got dark, the patient had a fever, we started worrying about malignant hyperthermia. Well, we're lucky nowadays. We have other ways to find out. So when anesthesia has an elevated CO2 level, they're going to start getting a little bit antsy, and then they're going to, if they see some increased oxygen consumption and some cardiac arrhythmias, they may ask you to bring the malignant hyperthermia card in the room. So you can get tachycardia, PVCs. Tachycardia is the answer. I know I passed out a test, and so the right answer is tachycardia. You have arrhythmias, unstable BP, there's sweating, you have the skin, masseter spasm. Back in the day, that's one of the things we looked for too. If the jaw muscles right in here got really tense and tight, they began to suspect that something was wrong. Just generalized muscle stiffening and respiratory and metabolic acidosis. And those are early signs. So here's your late signs. You get an elevated temperature, about 1.8 degrees every 3 minutes. So your first signs are not the increased temperature, but you got elevated temperature. So I know when you start the code, you're going to want to make sure the dantrolene is available. I know the first code we did, we all brought the ice. We all thought the priority was cooling down the patient. Actually, it's not the priority. You can send your PCAs for the ice or whatever you need them to do, and they need to get it up there, or the cooling blanket that I think only CB has. You guys still have cooling blankets for the beds, yes? You can send for that if you want, whatever is easier. But that is something you can have somebody else do while everybody else is concentrating on the drugs and stuff that you need. So then you have muscle contractures and muscle breakdown. So you can have the dark urine and stuff. You want to put a Foley in this patient. As soon as you suspect malignant hyperthermia, have somebody put in a Foley right away. But you want to check to see if they have that dark urine, so they have shows you that they have muscle breakdown going on. You get cardiac arrest, increased oxygen consumption, hyperkalemia, respiratory metabolic acidosis. So we're going to want drugs to counteract these two entities as well. So then you get DSC, left ventricular failure, and pulmonary edema, and possibly death. So when you get down to these 3 stages and you're finding things going on, it's very, very hard to bring these patients back. Okay, so how do you treat it? You want to discontinue all your volatile anesthetic gases. That's one of the first things anesthesia is going to do. And if they're given a nectine, back in the day we used to have a nectine drips. I don't see that very often anymore. And so you want to turn all that stuff off, because those are the things that trigger the malignant hyperthermia. And they're going to give 100% oxygen. Back in the day, it used to be change out the circuits, change out your soda lime, do all that. Now they're saying just if you don't have time for that, just flush it out with O2 as much as you can. I know the anesthesia techs will show up and they'll do as much as they can to change out what they can at the time, especially the soda lime, because you do have residual gases in the soda lime, all that blue, you want it nice and white. And you want to give IV dantrolene. There are another drug on the market now, but Methodist just has dantrolene in-house at this time. The cooling measures can include the blanket. You want ice, saline, we have that in, not ice, but cool. We have that in our malignant hyperthermia refrigerator. You want everything irrigated, will be cool. If they need a lavage through the NG tube, cool. You want to do, if they do rectal, if it gets to that point, everything needs to be cool, okay? Okay, so I told you, excuse me. So you're going to have cardiac arrhythmias, so we need to be able to treat those cardiac arrhythmias. So you want to give your antiarrhythmic agents, okay? Your urine output, really watch the urine output. You should have one-third of the cases usually result in acute kidney failure. You're going to get that really dark urine. And we're going to use sodium bicarb to treat the metabolic acidosis, as well as dextrose, insulin, or calcium chloride. All that stuff is in our malignant hyperthermia card. We've gotten really much better at that, but it was kind of interesting to see how horrific labor and delivery did, because they don't even know that they had malignant hyperthermia cards. So it's really kind of weird to see how far we've gone and to see other people just starting to recognize an episode of something, not knowing what to do when malignant hyperthermia was drill was presented upstairs. Okay, so we also have ABCDs of malignant hyperthermia. First of all, your agents. You want to turn off all your agents. You want to administer your dantrolene right away. That's your first line of defense. You have to ask for help. There is no way just the circulating nurse, the scrub, and the anesthesia can do this case by themselves, okay? And I'm going to go into what the responsibility is of each person. The charge person needs to know immediately because they may want to stop an elective case from starting if they need additional help in another room, okay? So the charge person needs to know immediately. We do ours internally, so they'll just, the charge person will kind of bring send the people to your room. We do not call a code overhead for malignant hyperthermia just like we don't for regular codes, okay? So it will be internal. Breathing, you want to hyperventilate this patient with 100% oxygen. They're just wanting that oxygen. They're just needing that oxygen, okay? Cooling measures, only if the temperature gets above 102.2, okay? We do not cool prior to that. Dantrolene, which is a continuous rapid IV push. If there's any way a second IV can be started, we need to start a second IV when people get in there, okay? Because otherwise it's going to be hard to get all this in. Okay, so what does the circulating nurse do? Okay, so you call for help, and when the help comes in, you should assign the nursing duties unless the charge nurse comes in and says they're going to do it. You don't want 100 people barking orders to 100 different people, then everybody gets confused as to what their role is. So one person will start assigning duties, and you should have somebody just strictly for medication. And usually I would assign 2 people because you need to drop 60 ml of non-bacteriostatic water to mix each vial of dantrolene. And then you're just going to keep mixing and handing them to be pushed IV, okay? Assign someone to inform other anesthesia personnel is available. When we call the front desk, they should be calling across the board to get help in there. Anesthesia needs some help as well. It'll be probably CRNA, probably a couple anesthesiologists, and an anesthesia tech should always come to the room for this. And the pharmacist should come, you guys. And the reason behind that is we only keep 8 bottles of dantrolene in our carts. You could use up to 30. The rest of the dantrolene is kept in pharmacy. So they will be getting the dantrolene for you if you need more, okay? Limit the new starts in the operating room. We already talked about that because you want to be able to have enough help to do everything you need to do. Okay, remember there's still a patient on the table and there's still surgery going on. So we have a patient in there, probably may have an open belly, whatever, so let's remember we have a case going on. So you may want to cover up that wound, scrub tack, and keep it nice and moist and stuff. Okay, medication nurse. Your therapy is aimed at treating all the signs and symptoms that this patient is having. So they have hyperkalemia, acidosis, arrhythmias, and you want to increase the urinary output. So you have to prepare medications as well. You may have just a dantrolene nurse, prepare that. You may have another medication nurse over here giving anesthesia the other drugs that you need. So you're going to need the sodium bicarb, right? Because you have metabolic acidosis. You want to increase your urinary output, right? So you need some Lasix. And the dextrose to treat the hyperkalemia, and the calcium chloride for the hyperkalemia as well. All these drugs, once again, are in your cart. Regular insulin and lidocaine to treat the arrhythmias, and my favorite word, amiodarone to treat the arrhythmias, okay? So, like anything, you have to document. What time did you give these drugs? What's going on with the patient? How's the patient responding to all these? We always tend to forget you need a documentation, just like a code. And we have chosen up to this point to use our CPR, our code blue sheet to go ahead and document for your malignant hyperthermia as well. The majority of your drugs are listed there, which will make it easy for y'all. You have to add the dantrolene, of course, but it sure would make it easier than having to start from new. Don't forget your times and your patient responses, okay? Okay, so you also want to do your cooling measures. If you did that, document that as well. Okay, so dantrolene is the drug for malignant hyperthermia that we use here at Methodist Hospital. Okay, so it acts as a skeletal muscle relaxer. Remember, your patient's muscles are really, really tight. We need to free that up and get those loosened up. You want to constitute with preservative-free sterile water, which is 60 mLs per every 20 ml amp. So remember, you could use up to 30 amps per episode. So just keep on mixing, okay? Just keep on mixing. The average use is 30 miles per crisis, and the dosage is usually 2 to 3 milligrams per kilogram, but it can be increased. That's, you know, when anesthesia asks for it, you have to be ready to go. You don't have time to wait to mix another vial. It's better to waste a vial than not have it ready when the patient needs it. Okay, the post-crisis, you want to watch for side effects like muscle weakness, respiratory depression, and localized IV phlebitis. I mean, this patient's getting a lot of drugs through that one IV, so like I said, try and start a second IV if at all possible. And you can't imagine what kind of pain this patient may be in afterwards with the muscles being contracted as hard as they had been prior. This is a new drug on the market. It's called Malignant. It's also a dantrolene sodium, and it's injectable. The difference with this is it comes in 250 milligram vials, and it only takes you about 10 seconds to mix it with 5 mLs of water. Isn't that awesome? It's fast administration with minimal fluid volume because you don't want to overload the patient. And we are, in the other instance, we are fluid overloading the patients because we're given 60 mLs every single time as well as every other IV that's going through and the other drugs that are going through. Potential to lower the risk of complication arising from treatment delays or the high fluid volumes. You typically only have to use one vial per up to patients for 100 kilograms. And one vial of Malignant is the same amount of dantrolene that you use in 12.5 vials. And it must, but the thing is it has to be used within 6 hours of constitution. And the reason we don't have it here is because it's very, very expensive. And because this is a low volume, high risk entity, we do probably throw away a lot of dantrolene or return a lot of dantrolene that we never use. So it's very expensive just to get one vial of Malignant. I don't know the price, but my understanding is it's in the thousands. And that may be the reason I can't speak for Methodist. I know that some of the anesthesiologists and the powers that be have discussed this issue, and if it changes, I at least wanted you to know that it is a drug that is available on the market. And this is just a comparison chart going over a lot of the stuff that I already talked about. But, okay, so cooling, what do you want to do? Hopefully most of us are using a bear hugger on our patients to keep them nice and warm. Well, we want to turn that off. We don't want to keep them nice and warm anymore. They're too hot as it is. You want to make sure anesthesia puts in an esophageal temperature probe. And it's in our cart, but it's also in their carts, and most of the anesthesiologists use it anyways. And if they don't have one in, then they want to put one in. And cooling will start when the temperature gets up to 102.2. They usually warm at a very rapid rate, so you want to go ahead and, like I said earlier, gather up all that stuff just in case, and have it ready to go when you're ready to go. We do keep gel pads in the refrigerator as well. We can pack the axilas and groin and stuff like that to get us started if we need to. So you want to have cold IV followed saline. We've talked all about all of this, so I don't want to rehash it since we have time limitations. And you want to also discontinue cooling measures when the patient gets down to 100.4. You don't want to go into hypothermia after the fact that we've cooled them down and have all this dantrolene. So the cooling measures do stop at some point. This is just a summary of everything that I've talked about. I'll let you guys look at it on your slide because I want to go through the tests at the end here. So those are just signs and symptoms, signs through everything we talked about, a little chart. After the MH crisis, you want a PSN. You have to report that PSN. You want to complete the surgery. Remember, like I said, we have a patient there. We have to figure out at what stage that patient's at. Do we complete it? I did a malignant hyperthermia on a kid with PE tubes. We didn't complete the surgery. We had one tube in. We didn't bring the patient back to put the second tube in. We didn't think that was vital to do that at that time. but I also did one on the spine. Of course, we had to close up the spine, so we closed up the spine as quickly as we could, brought the patient to ICU. You want to remain in ICU setting for 48 hours because you want to monitor the patient, make sure there's not a reoccurrence of the crisis. Okay, MH resources is very important. The hotline, it's for the whole United States, and they actually keep up to date and provide the best scientific research that's available at the time. So if you have any information or any issues, you can always call them, and they're open 24/7, 365 days a year. Somebody's there to answer your questions. Okay? They have an email and a website if it's not an emergency situation. I would imagine you're only going to use that phone number if it's an emergency situation, and you can contact them via email or their website if it's not. Okay? So malignant hyperthermia is a potentially fatal, but it's preventable entity. It's after exposure to certain anesthetic agents. Although common, the risk of mortality is still high, and you must be prepared in the OR to prevent malignant hyperthermia and treat MH if it occurs. So what's next? We're hopefully going to do the simulation next week. I have to reconfirm that. And kind of read your policy and procedure. We do have a policy and procedure in the operating room on how to deal with malignant hyperthermia. And remember, it's very specific to your unit. Labor and delivery have developed their own now, very specific to them because they don't have the same resources that we have. And there is a test. I don't know if we're given the contact hour today. I'll have to ask Irene whether or not we're having the contact test. Well, the test is not meant for you to do on your own. It's a group test to get some discussion going as well. Let me see how much time we have. Do we have time, Irene?
Time.
Okay. Malignant hyperthermia is 1, 2, 3, or 4. You don't have it? 4. It's all of the above. Okay. Who is at high risk for MH if you look at all those situations? 3. And why 3 over the other ones? Because the grandfather had a history. So that makes them at higher risk than the other ones, even though the other ones are at risk. Okay. What is the physiological event that begins with the cascade of MH?
Number 1.
Right. Because the calcium gets released into the skeletal muscle, causing it to contract. What is the correct physiological sequence of MH crisis? It's actually number 2. People get confused between 2 and 3. So you have to have a mutation in your RYR1 in order for you to even get malignant hyperthermia, right? And then you get the release of the calcium is the next thing that comes in, which is in both. And then you get the muscle rigidity, which causes metabolic acidosis. Okay? And then you get the increased temperature loss. So number 2 is the correct answer. Can you use up to 30 vials of dantrolene for one case? Yes. You don't have to, but you can. Okay, what's a good question to ask for a patient when you're assessing for malignant hyperthermia of these questions? All of the above. You want to know history. You want to know what's going on. Is bradycardia a sign of malignant hyperthermia? No, it's tachycardia, right? Okay, what's one of the first signs that an anesthesia personnel will see with malignant hyperthermia? Yeah, they're going to have an increase in CO2. Which is one of the first steps when malignant hyperthermia is recognized in the OR? Yeah, you want to call for help and get that malignant hyperthermia card in the room. I would suggest when you call the front desk and you're calling for help, you tell them why. That you suspect malignant hyperthermia. Because Lord knows what's going to come to your room if you don't tell them, right? So, what is a drug of choice for malignant hyperthermia? And what is a secondary drug that is available on the market that we no longer have, that we don't use? Right. That was a bad question.
I need a question.
Yes.
2, actually. What happens in the middle of the night? Who do we call?
We would handle it, I would think, like a code. You would pull the code blue button. Because that's what labor and delivery has decided to do, is pull the code blue button. and hopefully they've educated those people that responded.
Okay, and then the second question, you're saying call for help. We don't call internally over.
No, you call the front desk, ask for help, and tell them you have suspect malignant hyperthermia, get the card in, let the charge person take over from there, come in the room and bring in the stuff.
Is the sign
We do not call, you can call overhead in the OR, because it's only her
That's what
here.
I'm saying.
Yes.
In the OR.
Yeah, you can call overhead and say, and hopefully, what I'm getting at is the charge nurse will come in and take over from there and maybe assign assignments. Yeah.
Overhead here does not.
Where are the cards in our OR? Our malignant hyperthermia cards?
810.
Okay, we have, and where's the other one?
outside of 6?
Okay, we don't have one in Pod C, I just realized that.
No, we don't.
Do we need to have one in Pod C?
Right, it's,
Pod A?
it's, the other one's by the code part that's in Pod A.
Yeah.
It's right up there between 4 and 6.
That's the one.
So we do have some extra cold saline in Pod B's refrigerator, I know that. We have some extra ice packs in Pod B refrigerator as well if you need that. But send your PCAs regardless to get ice, like they do for the CDC when they need ice and stuff like that. Any other questions?
Not late.
I know I went fast, sorry. So I had 30 minutes exactly, so I read.